Welcome to this Peer Voice activity. To access the entire activity, including supporting material, go to www.peervoice.com/QZY. This activity is supported by an educational grant from Astellas and Pfizer.
Hello, I'm Andrea Necchi. I'm a medical oncologist, Director of GU Medical Oncology in San Raffaele Hospital in Milan, Italy. Professor of Oncology at Vita Salute, San Raffaele University in Milan, Italy. And I'm delighted to welcome today Melanie Costin, the patient advocate for Fight Bladder Cancer UK. Today, we are going to discuss the shared decision-making in patients with the bladder cancer. Why it's so important and how we can do this better altogether in order to improve outcomes for the patients. So there is clearly a shifting landscape in the way we manage currently patients with bladder cancer throughout the disease stages and throughout the lines of therapy. We got several approvals in patients with bladder cancer, starting from the very beginning for non-muscle invasive disease with newer intravesical therapies, going to muscle invasive disease with newer perioperative therapies, chemoimmune therapy or immune therapy, and ADC like enfortumab vedotin and pembrolizumab and radical cystectomy, and going to the advanced stages with the novel agents and novel combination, overcoming the limitations and the results that were achieved until quite recently by chemotherapy alone. In general, for the first line treatment of patients with muscle invasive bladder cancer or neoadjuvant treatment, we have together multiple options, in particular represented by the combination of enfortumab vedotin and pembrolizumab, which provided impressive results in either the patient population with cisplatin eligible or ineligible patients. So as compared to cystectomy alone or chemotherapy and cystectomy. So really, really good advances. In frontline systemic therapy for metastatic patients, same combination actually improved substantially the results that were available with chemotherapy, followed by maintenance of avelumab or chemotherapy alone. But there is clearly, from non-muscle invasive disease to advanced disease, an issue which is related to the availability and reimbursability of the drug. So Melanie, I would like to hear briefly from you, what is actually the patient standpoint with regards to drug access in a context in which there is an explosion of possibilities for the patients?
Yes, I mean, with this changing landscape, which is fantastic to have all these different options, there is a problem in the UK. We are maybe a little bit behind in some ways, in that patients can see all of these treatments, and of course it's really great for them to be able to have them, but can they get them? And it takes a lot longer time for us to get them over here. But not only that, it all depends where you live. We have postcode lotteries where you could be near to the hospital or far away. And if you're far away from a hospital, how do you get in? So there's lots of considerations to lots of things to think about as a patient.
Thank you, Melanie. So there are also different side effects profile, because we as oncologists have been pretty much aware of managing the toxicity related to chemotherapy or toxicity related to immune checkpoint inhibitors, much less we were aware with the management of ADC side effects, in particular enfortumab vedotin. So we have different possibilities for patient developing side effects, the need to involve different specialists since the very beginning. So again, Melanie, from the patient standpoint, how is it important to educate the patients to different or to newer side effects possibilities as compared to what we were used to do until the chemotherapy and immune therapy availability?
Yeah, well, it's about having a conversation on the differences and what a patient can expect, because a lot of people have preconceived ideas of what treatments mean, like chemotherapy might mean this, and what does immunotherapy mean. So some of the side effects, they look quite small on paper, but the reality is that the rashes are quite drastic, and if a patient suddenly wakes up with one of these side effects, they want to know what's normal, what isn't normal, and they want to have the confidence to be able to tell the clinicians, because there is a lot of times that patients don't want to mention all these side effects in case the treatment gets stopped. So it's all about communication and expectations and being honest about it.
Thank you, Melanie. So, Melanie, what is actually and why shared decision making is vital in patient management?
Yeah. So shared decision making is really not just about giving information. It's making sure that the patient feels included in the discussion, and it's not just about them, it's with them. And it's putting the knowledge of the clinicians and the lifestyle and the hopes and the dreams of a patient together to find the best outcome. So everyone's going to have different preferences. One size doesn't fit all. But having this talk, you will be able to hear what is important to the patient in their life. It could be to do with their relationships. It could be to do with the fact that they're working. But it's also to do with things like culture and personal beliefs. This could make a huge difference on what a patient really wants. So when the conversation goes well and there's a lot of confidence and you know, people are more happy with the way things are going and their decisions. But if you don't have this conversation, then there's people that really don't understand what's happening. They've gone through the whole of their pathway really without understanding what their disease is really about. So they can't have that conversation with you. And it's about trust. And it's not just for the time that you have the treatment, but it's much longer than that. It's for people who might think they might feel regret that they've possibly gone down the wrong route. And so there's a huge amount of importance to give to the emotional well-being and the mental health of people after their treatments have actually finished.
Thank you, Melanie. So I would say that this is particularly important in curative settings where when it comes to different possibilities, where the aim is the cure. Before we move on, please answer this challenge question. So there are critical points for the shared decision making throughout the disease management and the communication strategies, different communication strategies and needs, depending on the situation. Where we start from the beginning with the needs to get an important and insightful information on the clinical stages, on the disease the diagnosis, on the prognosis and therapeutic possibilities, going down to what is happening during treatment with regards to response, communication of response to a certain systemic therapy, and communication to disease relapse when it comes to a CT scan or MRI, which is documenting a disease progression or non-response to certain therapies. And when it comes to prognosis, at that time, so at the time of non-response or at the time of disease relapse under certain therapies. And finally, throughout the disease course, the possibility for the patient to be considered for clinical trials outside of what is happening, what is available as a standard of care therapies. So, Melanie, what is important from the patient standpoint to get, and what are the important messages in the patient management for the patient to get from the physician side when it comes to these different situations and the different communications points?
Yeah. So the important thing to realize here is that this isn't just one conversation. The conversation changes throughout. So, you know, at the beginning, people are going to need to have a lot of more emotional support. They're going to need to have a lot of explanations. There'll be a lot of questions and so on, and all the uncertainty that goes around it. But it's also the patient wants to be listened to along the journey as well, because if things change, the treatment isn't working or the side effects are intolerable, then that conversation about decisions has all got to start again, really. And this is when it gets to relapse, it's a really different situation because you've got different priorities will come into play then. People may not be thinking so much about the treatment and how it's going to help them. They may be thinking about quality of life, how it's going to affect their family, and making completely different decisions when things have gone wrong. So the conversation has to, you can feel like you can keep revisiting it as you go along and have the confidence to do so.
Thank you, Melanie. So, in summary, I think that being flexible enough from our side, from the physician side, to address the different situation or different needs that the patient may suffer or may need, depending on the situation, depending on the clinical stage, is important. Getting patient commitment and patient trust is important throughout the treatment course, and finally, discussing the opportunities for a different situation to provide and to administer different type of approaches is also paramount importance, including the possibility for the patient to be considered for trials. Now again, please answer this question. We are now going to walk through the key decision-making points, and we will explain what you need to cover at each stage and how to approach it to achieve the best outcomes for your patients. There are in literature, there are shared decision-making models and multiple models available. The common things of these models, common themes of these models are to best create the choice awareness, describe the treatment options, tailor information to each specific patient, so personalizing therapy, elicit patient preference, and finally to make a decision. So we have multiple tools. We are fortunate today because we do have the literature supporting this activity. Starting from the beginning, from the time of diagnosis, it's important for us, for both parties, clinicians and patients, to know what is actually needed to know from the patient side. From the clinician side, patient understanding, for example, the treatment choice in the shared decision-making process, the understanding information, how to best cope with the diagnosis, what is actually the meaning for certain therapies to start with, the treatment goals and objectives for treatment. The state of mind of the patient is important for us to consider, as well as any need for professional help, logistical barriers, logistical limitations for the patient to access certain therapies. So, Melanie, from the patient side, what is actually important to get at this stage for the patient?
Well, so at this stage, it can be completely overwhelming because patients are hearing about a lot of things that they've never heard of before, and treatments that they've never heard of before. But it's actually a lot to do with their lives and how they are as individuals, because they don't just need to hear about the stage and the grade of their cancer, and they want to know how well these treatments work. They want to know the side effects, but also there's a lot of impact on themselves as people, because if not everybody lives with somebody else. Some people are living on their own. They've got to manage maybe a huge operation. Will they get help with that? Where does the help come from? And sometimes people need to have prehabilitation before they start a treatment. And they really need to know where do they go to get some support, as in day-to-day questions on living, because there's so many changes. For a bladder cancer patient going through any of these treatments, it can be a really lonely place, and so they need to know where they can go just to ask not always the medical questions, but the day-to-day things about how they're feeling and whether a side effect is something that should be mentioned or not.
Terrific, thank you. And talking about treatments, we have different therapeutic options, as you have heard already. Systemic therapies, for example, cystectomy or surgery on the other side. We have already heard about newer therapies, and as a consequence, newer toxicities that the patient may face when receiving treatment. What are actually the best recommended options, depending on each type of toxicity or pre-existing toxicity communicated by the patient. Melanie, I would like to hear from you in particular when it comes to the issue of surgery, major surgery like cystectomy. What is actually important to know from the patient side?
It can be the most things that you would never imagine people would be thinking about, because it's not always about the image, what they're going to look like. how they're going to actually manage their bag and their stoma or whatever they have to manage, but it's about how they're going to live afterwards, and whether they'll still be able to work. For example, we've had people ask us whether would they be able to swim. These are really the sorts of questions that you might not think a patient is thinking when we're talking about cancer, but some people are thinking about life during treatment and afterwards. So it's about setting the expectations and making sure that they understand what's going on, and the differences where sometimes you need to have chemotherapy before surgery, and they don't understand why you then need to have it afterwards. So I think it's just clear, compassionate conversations is the main thing, and also signposting them to any support that they need.
Thank you, Melanie. Before we move on, please answer this challenge question. So, discussing treatment response. So we have started treatment, and we have now the response assessment to systemic therapy. So again, clinician side, patient side, what is important to know in the shared decision making? For the clinician side, for example, what are the concerns and fears at the time of discussing a disease response? What are the emerging barriers when it comes to discussing different therapeutic options or a change in therapeutic options? What are actually how is patient coping with the response? So, Melanie, from your standpoint, what is important to communicate to us as a physician, to communicate as important thing to know when communicating response to certain therapies?
Yes, well, this is a very frightening time, when you're finding out what's actually happening, whether this treatment is working, or what's going to happen next. The conversation can completely change. So bringing into shared decision making, this is another time where it's really important, because the goals may have changed, priorities may have changed. So what now? If it's responded, then what happens next? That's kind of a normal question. But what are the implications if I'm not responding that well? What's going to happen to me? Is there anything else that I can have? Or what will happen if I just suddenly switch treatment? Is that going to make any difference? Surgery could be involved, and they hadn't thought about this before. So there's a lot of support needed at this point, and just explaining what the treatments are, the side effects, and how these options might be sequenced, and giving them the permission to ask and feel confident to ask the questions, and also what would happen if I did stop having any treatment. So that's also something very important.
And then we have an even more critical point that we're communicating relapse. So we do have the disease response assessment, and we are now facing of disease relapse during treatment, a worsening of the disease documented by imaging, for example, or the clinical symptoms. So what are actually the challenges at this time point? In particular, from the clinical standpoint, for the clinician standpoint, is important for us to get and a hint regarding the possibility for clinical trial inclusion, or what is actually the patient's state of mind, what is actually the patient commitment to pursue any kind of further systemic therapy, what are their fears, what are the limitations and challenges in getting an additional line of therapy or getting access to clinical trial. Or these things are very important to share to the patient and to try to envision the next step forward. From the patient side, Melanie, at this time point, actually, the disease relapse felt by the patient side.
Yes, so this is a point that the communication needs to be very honest and very supportive. A patient is generally going to feel very emotional and frightened, exhausted. They've gone through all of these things, and it's not looking so good now. But there's still hope. There could be other things that they could have, because a clinical trial might be suitable for them. So they would need to know why they may or not be considered for a clinical trial, what's available, and being realistic as well. I think people appreciate that. Some people really want to continue on with very strong active treatment, but other people may start having different priorities at this time, and quality of life, time with family, all of these kind of things may actually become their priority. So it's another time where obviously you've got to have that honest conversation and listen to each other, really.
Thank you. So in brief, each time from the diagnosis to the response assessment to the time of communication of disease relapse, always consider not just the therapeutic possibilities, but patient side, the patient perspective regarding the commitment to pursue additional therapies, availability of newer therapies, and always frame everything, every consideration into the life of the patient and the patient expectation and situation. Now, please answer this challenge question. Thank you for watching.
This has been an activity published by Peer Voice.